We have a myriad of presentations to cover some of the hottest topics that practices are going to be facing here in 2014. Can you believe it's 2014, Brian Bell?
Absolutely not.
Things at Coalfire are looking good for you guys this coming year.
That's putting it
All right, good. Well, let me tell you a little bit about Brian. Well, Brian is the director of the Southeast region at Coalfire Systems. He has extensive experience in audit, risk management, compliance, payment card systems, information security, data centers, and co-location. Also, application development for their customers. His experience includes serving clients in compliance efforts for PCI, HIPAA, CMS, ISO 27001, and FSMA. A seasoned professional with over 22 years experience in information technology. His past, he served as Vice President of Technology and Information Security Officer for an Atlanta, Georgia-based company. They also had compliance initiatives similar to the background and experience he has. For more than 5 years, he handled intensive security audits by government agencies and multiple Fortune 500 companies. Brian Bell, welcome to Moro.
Thank you. I've got a couple specific things that I wanted to cover. The main thing that I wanted to discuss is just the fact that, real briefly, just talk about how the healthcare industry has evolved over the last several years, over the last decade, really. The fact that the original security, HIPAA security rule hasn't really changed. All they've really done is expanded the scope and the penalties for not maintaining security. I'm going to touch briefly on the difference between security and compliance. There's a dramatic difference between the two. The main thing, though, is I really want to focus on the fact that implementing fundamental security controls for PHI protection, data protections and systems, whether you're a CEO or a BA, are actually not extremely difficult. They can be, sure, you know, we can get into a lot of details about crazy encryption and access control and system communications, but there's some really fundamental things that you can do. And after going through these 7 core fundamental security objectives, if you implemented these 7, number one, you've done so using minimal costs, but at the same time, you're well over 50% toward HIPAA compliance. I would probably say you're closer to 75%. So we'll spend some time going through those. A little bit about Coalfire, just 2 seconds. We focus predominantly on gap assessments, information security consulting. We don't sell products. All we do is provide security consulting. We provide report of compliance. So in the end, you could have not only a very clear roadmap on how to clean up or implement security controls that you need for HIPAA compliance, but also end up with a third-party attestation of your compliance that allows you to share that with your clients as well, or you know, the HHS or OCR if they decide to show up. HIPAA regulation or healthcare regulation, just go over this real briefly. Most of you are probably familiar with this. The point here is simply to say that the HIPAA security rule really hasn't changed. The security controls that were developed nearly a decade ago, in many cases more than 10 years ago, haven't really changed. The only thing that's really changed is the fact that the scope of who's accountable to those security rules has expanded through Omnibus, as well as the fines that are associated with data breaches. In the next slide, one of the main points that I really wanted to make sure that you understand is the fact that when the OCR shows up to do an audit after following a data breach, I've actually been on site with a few large hospitals, well over 1,000 beds, where the OCR was on site following a data breach. The number one thing that they look for is determining whether or not there was negligence or whether there was simply an unknowing data breach of PHI data. There's a dramatic difference between the two. In the year 2014, it would be very difficult for you to explain to the OCR how this new information security protection and encryption is this new thing that you haven't heard of before. So if you don't have these fundamental controls in place, the fines are going to get very expensive. The fines are per day, per record. So if you looked at the numbers from the previous slide, $10,000 to $50,000 for large organizations, they're thinking, well, you know, the cost of actually implementing a lot of reasonable security controls are going to cost well more than $10,000 to $50,000. You know, that's entirely possible. I would also argue that there's some very fundamental best practices that you can put in place to minimize your risk and exposure without spending a ton of money, and that's what we're going to cover today. But the point is that those fines, $10,000 to $50,000, is per day per record. So that can add up to millions of dollars in a hurry. Compliance and security are not the same thing. I want to touch on this very briefly. I think the overall intention is that compliance is intended to mean that you've got fundamental security in place. However, one of the things that's important to keep in mind is that the security rule, HIPAA, was originally passed back in 1996. It's nearly 20 years old. I don't think there was a real strong understanding of what the totality of information security was back then. There were technologies that didn't even exist back then. So there are fundamental weaknesses in the HIPAA security rule. There are some strengths as well. One of those being the risk management program. And the risk management program is kind of the catch-all for the HIPAA security rule. There are several deficiencies. If you look at HIPAA, the HIPAA security rule in general, and compare it to something like CMS, CMS is probably 5 to 7 times a larger security program with significantly more controls and requirements than HIPAA is. So, but the HIPAA catch-all is the risk management program, which basically says this. It says that regardless of what the other controls are that you have in place, you have to do a risk assessment for your environment, how you're operating and who you're sharing data with, to make sure that you have adequate controls in place. So it's kind of their catch-all that says, well, okay, you did all of the security rule objectives, you met all those controls, but at the same time you're doing this separate process, you're doing these other things with your business associates. You should have identified the fact that this was a point of risk and added additional security controls. Okay, what I've come up with is a list of the 7, I guess I would call them just baseline fundamental security objectives. These are things that can largely be implemented without spending a lot of money. For security professionals, they'll probably look at this list and say, oh, well, you missed 2 or 3 other things. The intent, though, is to give you the highest impact security objectives that's going to get you the furthest down the road with minimal expense. There are additional things that you might have to do for a complete security program. However, this will get you probably in the 75th percentile of HIPAA compliance. Okay? So, first thing I want to talk about is what we call network segmentation. Networks of the past, traditional networks looked a little bit like this. The hacker you see on the left there, really their intention was to come in and all they had to really do is break through the firewall. And at that point, they're inside the network. If you notice, the main point here related to network segmentation is the fact that the workstations, the data, the printer, the server, everything's on the same network. So all of the systems can communicate with every other system. Today's networks are exponentially more complicated. You're dealing with smartphone apps, you're dealing with tablets, you're dealing with laptops. We have a huge implication to security with BYOD, bring your own device. How many employees or physicians are bringing their own computers into the office that likely do not have the baseline security controls that you've established for your organization? You're interjecting significant risk into that environment. So, what's the solution? Network segmentation. Network segmentation says that we're going to identify what we call security zones within the environment, and we're going to put those systems and computers behind a firewall interface. The firewall interface denies all traffic into that network segment, so nothing can talk to those computers and systems except the ones that you specifically allow. So you have a default deny all policy, and as you have a business justification for accessing systems in that zone, then you open up those specific rules in the firewall to allow very limited traffic to come in there. I was working with an organization just a few weeks ago where we actually went through a workshop and designed a network segmentation security zone model for their organization. And the thing that they really liked about this is the containment of viruses. So you should have antivirus software running on all of your systems, obviously, but inevitably, who knows how many thousands of people are out there trying to write new viruses and hack and do different things. So inevitably, you may end up getting a virus on a system. What network segmentation does is localize the impact of that virus to the one zone that the outbreak occurred in. So that virus doesn't have physical access across or logical access across the network into the zones where you're storing very sensitive medical information, like your EMR systems and some of your back-end radiology systems. There's a dozen different areas and departments within your organization where you're storing that sensitive information. One of the fundamental questions is, for example, does the radiology department really have a need to access systems in the pharmacy? Well, typically not. You may have a reason for one or two that need to do that, but by implementing network segmentation, if you had a virus outbreak or you had a data breach, maybe someone has compromised one of the systems in that particular area, they have no access to the other critical departments within your organization. So network segmentation is a very powerful security measure. The point here as well, and talking about the financial implication and the way you can implement these controls, is the fact that most of the time you can leverage your existing infrastructure to implement network segmentation. Most every organization has firewalls. It's simply a matter of carving out your network and putting systems in logical security zones. So you may need a level of expertise, you may need some consulting, but you're not looking at a significant amount of money to go out and buy firewalls. Even if you did, I mean, you can buy a firewall for a very high-end Cisco firewall for a few $1,000s. Security awareness training. HIPAA is very heavily focused on security awareness training. This is something that you can develop internally using information readily available on the internet. I generally kind of break out security awareness training into 3 different categories because the type of training that you need to deliver would vary based on who your audience is. But you don't want to create a model where you've got to create multiple different curriculums for a dozen different teams and people and things like that in your environment. So what you're going to really want to focus on is probably breaking it down into those 3 areas. One is information technology. Your systems administrators, the people who are managing those systems, need to go through a different type of security awareness training than normal users. You've got your software development staff, if that's applicable. People that are writing applications definitely have to go through a separate type of security training. And then you've got the general training for physicians, administrative staff, and basically everyone else. Again, these are things that you can leverage internally with internal staff, and the information is largely available on the internet. You're not talking about significant expense, and this is a major objective within the HIPAA security world. System hardening. One of the great questions that I enjoy asking when I'm doing assessments and helping people work through their security program is, as we're going through, I mean, whether it's BAs or CEs, is fundamentally asking them, okay, is the system that you're working from, does it contain sensitive information? Does it contain PHI? If it does it have internet access? And why does it need internet access? It's surprising how many times we ask that question, and it's like, well, I need to check my personal email, or I need to do one thing or another, but there's really not a strong business justification for doing so. That's a huge implication, because the impact is that you've got a system that has access to thousands, tens of thousands potentially, of medical records that also has direct access to the internet. The ability to export that data out to an unsecured network would be fairly simple. There's some fundamental things that you can put in place. Proxy systems, URL filtering. OpenDNS is a great resource. If you're not familiar with it, it's actually free for most organizations. I think there's a small fee depending on how you're using it, but OpenDNS basically filters external websites. So we're basically saying if you do have a business justification for going to the internet, use tools like that to filter and make sure that you're not accessing malicious websites. Configure antivirus updates so they can't be turned off. Do not add users to the local administrators group so that they can modify and change services in the security profile of the local system. Again, all of these security measures are things that you can do with internal staff, and you can research this information and create a system hardening standard using information readily available on the internet. Data encryption. I think most everybody's familiar with the concept of data encryption. I'll just spend 2 seconds telling you about an incident that I ran into. It's amazing to me how many large EMR systems do not support encryption natively. It's very surprising. So what the vendor usually says is we rely on the CE or BA to implement their own style of encryption, whether it's hardware disk encryption or database level encryption or whatever the case may be. I actually had the CTO of a very large CE debate the whole encryption thing with me and just say, well, it's addressable in the HIPAA security rule, and we think it's going to put a negative performance, have a negative impact on the performance of our back-end systems, and we got to go spend money. You know, we got to go spend $7,000 or $8,000 for some of the encryption things. So I actually I couldn't come up with a strong business justification for not using encryption. That's a difficult thing to do in 2014 on why you would not need to use encryption of your core back-end systems. So they sent the report, the findings report, to the HHS, which I thought was interesting. So the outcome was basically that the OCR security representatives that we worked with said not only is the findings report accurate and you should have an extremely strong business justification for not using encryption, we also want to hear what you decided to do after you get through this process. So it was not the best thing to do to contact the OCR on that. Again, a lot of this is encryption is capabilities and things that you can do with existing platforms and systems most of the time. It's surprising you can't necessarily do it at the EMR system level. You can do it with database and disk encryption as well. Documentation, I'm just going to fly through this really quick. I know we're short on time. Documentation, again, a lot of this information is readily available. You can put together specific plans. So after you've gone through security awareness training and you train people on how to identify potential data breaches, viruses, suspicious system activity, what do they do? Do they know what the incident response plan says and how do they supposed to react and who do they inform in those cases? So again, documentation is a pretty straightforward thing that you could do internally. PHI inventory. This is a very big deal because if you don't know where your PHI resides, how can you protect it? It's amazing how many organizations that I go into that can't quantify where the data lives, how many systems it's on. They don't know who they're sharing it with. They've got a dozen different BAs doing business with other BAs, and they can't quantify who all they're delivering that PHI data set to. Again, this is a major requirement in the HIPAA security rule. You can do with existing staff, and the organization and the means about doing this is pretty straightforward. Risk management program, this is kind of the cornerstone of the HIPAA security rule. Based on everything else that you've looked at and all the different security measures that you have to have in place, at the end of the day, what is appropriate for your environment? Are there additional controls that you need to put in place? The risk management program, the de facto standard, is NIST 830, and we used an example here of just mobile devices as an example of how to walk through that risk management program. There's the resource on Health IT Gov, gives you a lot of really good information. So I'll wrap it up with this final statement. The punchline is this: the HHS, over the last couple of years, by the expansion of the scope of who the security rules apply to, BAs, their BAs, whoever they're sharing PHI with, plus the dramatic increase in fines, is basically sending the message that fundamental security controls for protecting PHI should be in place, and the only way the HHS can kind of get the industry moving is to increase the fines. And so that's kind of what we're seeing. So what I've tried to do is give you a real brief, very high level, low cost, high impact approach to implementing security.
Thank you, Brian. Let's hear it for Brian.